And welcome to week 7, and we are this week going to take a look at another layer of EKG reading. So I want to remind you to go backwards and take a look at the previous chapters because we're piecing everything together. So we are only going to focus on enlargement. So how can we take a look at an EKG and be able to see if either the atrium or the ventricles have enlarged? And there's different underlying pathological reasons why this would happen, where things would get bigger. We are, for right now, just focusing on what it means on an EKG, not necessarily clinically, which we'll talk about later in the semester. So some of the things I want to make sure that we are able to do is basic pathophysiology of right versus left atrial enlargement and right versus left ventricular enlargement, right? Those are our 4 chambers. Be able to identify all of these on an EKG. So what is the basic behind it, and then how do we identify it, understand the causes, understand basic treatment. What does that mean to us clinically, right? So number 5 is what are the clinical implications? So to start with, when you're thinking about enlargement, we are looking at size. So changes in amplitude, so the size of the waves, morphology, which means the shape, and or the duration of the P, QRS, TST segment, any of these can indicate something is going on differently, right? For this lecture, it means either atrial or ventricular enlargement can be happening. Enlargement can again be of the atrium or the ventricle, so it could be right atrial enlargement, RAE, left atrial enlargement, right? Or very, very common, you hear a lot more, is the ventricle, so left ventricular hypertrophy or right ventricular hypertrophy. So you can see how those are abbreviated with their initials. When we take a look at the atrium, so the first few slides are looking at the atrium, P pulmonale or cor pulmonale, this results in the atrium. Something is going on in the pulmonary system, right? So just think about what you know about the physiology that we did back in the beginning chapters. So when you've got some type of pulmonary system breakdown, we may end up seeing this overload that happens with the enlargement of the tissue, the actual chamber enlargement. And what it looks like on the EKG itself is it looks bigger. When I say it, I'm talking about the atrium, so I'm talking about the P wave. So the appearance is big, the atrium is big, the atrium is what's making the P wave. So we see tall P waves. They're usually symmetrically peaked in leads 2. Remember, lead 2 are usually what we're going to be looking at. So you're looking at height. The height of the P wave is a little taller than usual. You also, the word biphasic, a biphasic P wave in V1. So the positive portion is greater than the negative portion. So a biphasic is kind of an up-down hump, right? Up and then down, 2 bumps, right? 2 lumps. So in V1, you're going to see that more, the positive portion and then more negative. So here's an example of number 1, just P waves that are taller. So this is a picture of showing you just the lead 2. We've got tall P waves. So tall P waves means that we're going to have more cells, right? More cells mean that the contraction that those cells are going through is going to give us a bigger wave. So a tall P wave means an enlarged atrium, right? When we're taking a look in here, we don't know by just looking at this lead, are we looking at a lead, are we looking at right side versus left side? So here I want to talk about right atrial enlargement. When that right atrium gets bigger, right? The cells, the thickness, the chamber itself is bigger. We see this happening when there is, over time, prolonged periods of time with low blood oxygen levels. You can see this with patients with pulmonary disease, COPD, valve problems, tricuspid valves, pulmonary embolism, cystic fibrosis, which is something you're born with, kyphoscoliosis, obstructive sleep apnea, many different underlying reasons why there's low oxygen levels. And the treatment for right atrial enlargement could be pulmonary vasoconstriction, cellular proliferation, thrombus prevention, different things. Again, we're not looking at treating, we are just looking at, can you recognize on an EKG that maybe we have a right atrial enlargement. Many times it's benign, it's not a big deal, but it could in time lead to a pulmonary embolism. So a lot of the signs and symptoms, are similar to that of an infarction, so just not getting enough blood flow. The left atrial enlargement is overload, so pressure or volume overload, usually secondary to increased left-sided afterload. So when LV, left ventricular dysfunction, or mitral stenosis, that's the valve, is present, we end up having a pressure and a gradient difference. So what you're going to see on the EKG for an left atrium is wide, notch, prolonged P waves in lead 2 and a biphasic P wave in lead 1. So here we see wide notch. You see the P wave doesn't look like one hump, right? That's biphasic, right? So it's notched. It's not just the regular hump, and that's what we see in left atrial enlargement. So right atrial enlargement, pretty much tall P waves, right? We got the tall P waves. In left atrial enlargement, you notice the P wave is now notched, right? So that's kind of what we're looking at there. This is what we call a biphasic P wave, where you can tell by that P wave, right? It goes, you got, if you can see my cursor on my screen, right, a lump. So biphasic, a hump up and then a hump down is biphasic P wave. So with left atrial enlargement, again, chronic hypertension, overload, pressure overload. When someone has left atrial enlargement, if the diagnosis is LVH. So just to kind of preface this talk, we are right now talking about the atrium. Most common, probably 90% of your time in a clinical setting, you're going to be looking at hypertrophy problems, ventricular hypertrophy. So if the diagnosis is left ventricular hypertrophy, which is very common, if it's confirmed, you also want to then go backwards, look up the heart and say, well, if this fella has left ventricular hypertrophy, there's a high probability we're probably also going to see left atrial enlargement up in the atrium. So when we see atrial enlargement, it's usually blood pressure, left side blood pressure management that needs to happen because the pressure is too long. You see it with obesity, you see it with people that are aging. So here is in a nutshell what we're looking at. So we're looking here in the last few slides at the atrium, enlarged atrium, right? So we've got our SA node sending contraction. If this tissue, if these chambers get bigger, our humps are going to change. So a normal P wave, right? Nice normal P wave in lead 2, regular looking P wave in V1, right? That's your chest lead 1. If it's a right side hypertrophy, remember I told you it's very tall. So we've got tall P wave. We're only looking at the P wave because we're only looking at the atrium right now. V1, kind of similar looking, right? So this is right side. On a left side, now we've got it prolonged and we have it notched. Right, you have that notch, the lump and the lump. So again, all of these notches look different, right? This notch that I'm showing you on this photo looks different, but similar to this notch I'm showing you here, right? That notch looking P wave. So showing you this table, you're seeing that in lead 2, a left atrial. So this is right atrial enlargement, left atrial enlargement, and then a biphasic, very biphasic P wave in V1. Anyways, so you might need to pause and rewind my voice and go over that again. So if the atrium is enlarged, the P wave is going to look different. If it's a right side, you're going to see a tall peaked P wave. If it's a left side, you're going to see more of a notched in lead 2 and a biphasic in lead V1. Let's look down at the ventricle, because again, as I mentioned, this is what we see more commonly. I'm going to spend a little more time on the ventricle. So usually the right side is asymptomatic, benign, dyspnea, dizziness, syncope, edema, overload, some episodes of a fast heart rate, sinus tachycardia. Right ventricular hypertrophy, what it's going to look like on an EKG. So remember, now the left ventricle has gotten wider. If you remember last week, I told you we're going to learn how to do axis, right? So that's when you look at leads 1 and AVF and you decide what axis the heart is in. Now, if somebody has right hypertrophy, the axis is going to be shifted. Think about that. That makes sense. The thickness of that ventricle has gotten wider. There's more cells for it to contract through. So right axis deviation may or may not be present. Usually it is. So that means it's shifted over to the right side. So remember, go back to your chapter on axis. The other thing we see with an right ventricular hypertrophy is tall R waves, height, right? Everything gets taller, you got more cells. More cells means more contraction. It's going to appear bigger on EKG tracing. So when we looked at the atrium, we had a big P wave. When we're looking at the ventricle, as you see here, you've got a tall, big, tall height R wave. So usually the R wave is going to be tall in V1 and V2 because we're on the right side. Guys, remember those electrodes for V1 and V2 are more on the right side of the chest. So that is the right ventricle. So you're going to see tall R waves, more on those right leads. RS ratio is going to be bigger again in those same two right leads, V1, V2. Right ventricular strain is pretty evident, and then you usually have deep S waves in the chest leads. So this is what it looks like, right? So right ventricular hypertrophy. Here's my V1 and here's my V2, right? So tall looking. Look at how much taller these right sides are to V5 and V6. Those are over my left ventricle, right? V5 and V6 are lying over my left side of my chest. But over here, we see very tall R waves. This is indicative of a thickened right ventricle. So an enlarged hypertrophy ventricle. So that is kind of our classic that we're looking at in the V leads. The other thing in V1 and V2 is you have your RS ratio. Again, what would cause this? Pulmonary valve stenosis, hypertension, chronic mitral stenosis. Anyways, symptoms. Usually they're going to be on medicines to relieve some of that respiratory distress that they're in. The ventricular septal defect could increase over time, which we haven't really spent a lot of time on the ventricular septal defect. I want you to know that the R wave is tall in the V's, right, those chest V1 through V6, more on the right side, less on V5 and V6, which lies right over that left atrium. So people with right ventricular hypertrophy and pulmonary disease, everything right goes wrong, right? So what does it goes wrong? We have right axis deviation, right atrial enlargement, right ventricular hypertrophy, right bundle branch block. We'll talk about that next week. So think about that. Right ventricle is talking about pulmonary, right, with the right side of the heart, and we say everything right goes wrong. What could go wrong on the right side? Axis deviation, atrial enlargement, hypertrophy, and a bundle branch block, which we'll talk about. We haven't done all those, but you'll come back and realize that makes sense. Let's move over to the left ventricle. So when we take a look at the left ventricle, now we've got an enlarged hypertrophy of the left ventricle, LVH. Very indicative, very correlated with mortality, high cardiovascular morbidity in patients with hypertension. Remember that silent killer is hypertension. Long-standing years, too many years of high blood pressure. Now we end up with a thickened left ventricle because that ventricle is overworking. That pressure is so high in there. All those contractions, all that blood coming out of that left ventricle is causing more cells, and now it's bigger. Independent risk factor for coronary heart disease, sudden death, heart failure, and stroke. Left ventricular hypertrophy is not good. And again, its number one cause are people who go untreated hypertension. So chronic and untreated, obviously, it can lead to life-threatening ventricular arrhythmias, which would be sudden death. What does it look like? On the EKG, the QR is complex. Upper limit, somewhat normal, but I want to go back to the R waves. Taller than normal R waves, deeper than normal S waves occur in those right chest leads. So at the S, which we haven't talked much about the S wave in V1 and V or 2, plus the R wave height in V5 and 6. So I feel like most students, when you're looking at the hypertrophy of the ventricle, makes sense, I think, for you to remember the R wave, the height of the R wave is changed. Is the R wave tall in V1 and 2, is 3, 4, right side, or what's going on over in the 5 and 6? So left ventricular strain pattern in the left chest leads, what does that look like? I want your eyes to just jump over here to V1 through V6, right? V1, V2, V3, 4, 5, 6. They are so tall, these R waves, they're running into each other, right? Also take a look at those big, deep S waves. So R and the S waves. So what we're looking at in this photo is left ventricular hypertrophy. Again, what are the causes? hypertension is really the cause. So we know that as, maybe you know this as a renal angiotensin aldosterone system is overstimulated, sympathetic nervous system, over time, elevated afterload, promoting chronic increase in workload, and the person ends up with very elevated systolic blood pressure, and physiologically, that left chamber is enlarged. It's overworking, it's getting thicker, right? It's not good. So the hypertension is linked with aortic stenosis, increased filling of the left ventricle, heart CAD, coronary heart disease. Basic genetics can be a trigger, and mitral valve insufficiency. So the way they treat, the best way to treat this is medicine. So angiotensin II receptor blocks or an ACE inhibitor. These are medicines. A diuretic, which you know is a water pill, or they can go in and do an aortic valve repair or stenosis. So clinical significance is left ventricular hypertrophy is not permanent in all cases. Growth and regression can happen with blood pressure changes and strict control of emotions and excitements and what's going on in the sympathetic nervous system. However, it is important to recognize that severe pathological left ventricular hypertrophy could be a precursor to what we know as just full-blown sudden death. So when you're looking at hypertrophic cardiomyopathy patients, they may also have CAD, but may or may not appear during exercise. So what this means is that left ventricular changes on a 12 lead can mask ischemic changes that could be happening with exercise. So in left ventricular hypertrophy, just like I showed you earlier, the picture earlier, so QRS. So what is the difference between V1 on the right side and V6 on the left side? So this is a normal QRS, right? Here it is with left ventricular hypertrophy, right? So in V1, really deep S waves, and V6, really tall R waves. So the amplitude, the height changes. And why does it change, guys? Look at how thick this cell is. All of these cells have gotten bigger than what it was up there, so it's going to leave a bigger line, a bigger imprint, a bigger tracing on the EKG, right? This is right hypertrophy, this is left hypertrophy. So being able to understand the differences. So here with right hypertrophy, here's just basic lead 1, here's lead 3, but here I was mainly, this lecture been talking about the V's, V1 through V6. So the height of the R wave on the right side is much taller than the height of the R wave over there on V5 and V6, which lies over the left ventricle. So the right ventricular hypertrophy, tall R waves in those chest leads. Notice that the R wave is can be small because the right ventricle doesn't have a lot of muscle mass, but the hypertrophied right ventricle is much taller. So this is the normal heart, right? This is the height of V1 with, let's say, your heart, and then you take someone with left ventricular hypertrophy and you see the height of that R wave is much taller. When we're looking at left hypertrophy, I want you to compare these two leads. So the QRS complexes are very tall. So here is a V5 with normal heart, and now look at how much taller it is. Why does it get taller? Because the size of the chamber is thicker. There's more cells. So this is a really nice, I think, table comparison of what goes on in the left ventricular hypertrophy and right ventricular hypertrophy. So we're going to go back and look at axis deviation. So why would the contraction, the contractility, or the direction of the conduction change, which is what we call axis, right? Axis deviation, because you no longer have a healthy heart in that normal quadrant. The wall has gotten thicker, and it's going to shift, deviate the direction of that polarization, the conductivity that's traveling through the conduction system. So I know last week when you thought about axis deviation, you were like, well, what am I learning? What does this mean to be in the normal quadrant versus right or left axis deviation? Well, now that you're learning about hypertrophy and enlargement, this is what would shift that conduction to go into a different direction. This needs to be broken down into smaller, take some notes, the atrium versus the ventricle, the P wave versus the QRS, and I look forward to reading your quiz questions that you make this week.